Assalamualaikum, my respected teachers, my colleagues and dear inter-doctors. Good morning, everyone. I am Dr. Kamalika Yasmin, lecturer, Department of Biochemistry. It is an honor for me to welcome you all in the weekly seminar on behalf of the Department of Biochemistry, CBMCB. The topic of today's seminar is comparison of renal function test among patients with acute stroke and normal healthy individuals. The seminar will be chaired by Chairperson Professor Dr. A.S.M. Shohidullah, Professor and Head, Department of Biochemistry. Co-chairperson, Professor Bina Sen, Professor, Department of Biochemistry. Resource person, Professor Dr. Aminul Islam, Professor and Head, Department of Medicine. And Dr. Mahmoud Javed Hassan, Associate Professor and Head, Department of Nephrology. And today's speaker, Dr. Sabina Momtaz, Lecturer, Department of Biochemistry. Now, I would like to request our chairperson, co-chairperson, and both resource person, please come to the dais and to take their respective seat. And I also request our chairperson to conduct the rest of this session. Thank you all.
Assalamualaikum and very good morning to everyone. On behalf of Biochemistry Department, I extend warm welcome to all present here at today's weekly seminar. As the gentle breeze of late autumn bids farewell and the cool touch of winter begins, it gives us immense pleasure to gather once again for this academic session. We are deeply honored to have with us our senior teachers, our colleagues and intern doctors. Your presence adds great inspiration and encouragement to our department. Today's seminar will focus on a very important and interesting topic. This is a research work. The comparison of acute renal function test among the acute stroke with normal individual. This research work is conducted as a part of MPhil thesis work by the Dr. Sabrina Momtaz, a proud graduate of CBMCB, CB13 batch. After completion her graduation here, she completed her MPhil degree in Biochemistry at Mymensingh Medical College and is now served as the dedicated faculty members. We congratulate Dr. Sabrina for her scholarly work and contribution to the field of biochemistry. Now I would like to invite her to present her research findings in front of us. Ladies and gentlemen, please welcome Dr. Sabrina to deliver her presentation. Another research person, please come to the dais.
Respected chairperson, respected research persons, respected teachers, my senior and junior colleagues, and beloved intern. Assalamualaikum and very good morning. Me, Dr. Sabrina Momtaz, welcome all to today's scientific seminar. It's a great pleasure to have the opportunity to share my study findings with you. Without further delay, with the permission of chairperson, I would like to deliver my presentation.
Title of the today's study was is comparison of renal function test among patients with acute stroke and normal healthy individuals. Stroke may be defined as rapidly developed clinical sign of local or global disturbance of neurological functions lasting more than 24 hours or leading to death with no apparent cause other than of vascular origin. Stroke emerges as the predominant etiology of neurological disability. Acute brain stroke arises from the interruption of blood supply to the brain caused by insufficient blood flow, blockage, or bleeding. Stroke can be classified into two primary types, ischemic and hemorrhagic. Ischemic stroke most frequently accounting for 50 to 85% of stroke caused by clot in supplying blood to brain. Whereas hemorrhagic stroke is responsible for 7 to 27% of all stroke arises when there is bleeding in the brain tissue or subarachnoid space. Stroke has emerged as a dominant non-communicable disease, ranking as the second most common cause of death and the third most common cause of disability globally. Worldwide, there are an estimated 12.2 million new cases of stroke each year, which account to one stroke occurring every 3 seconds. Global incidence of ischemic stroke was 77 million incidents, while the number of intracerebral hemorrhagic cases was 21 million in 2022, resulting 6.55 million deaths and 143.23 million disability-adjusted life years. Prevalence of stroke in low and middle economic countries has risen 70% from 1990 to 2019. WHO placed Bangladesh at the 84th position globally in terms of stroke-related mortality rate. Stroke is the third leading cause of mortality, responsible for 134,166 deaths, which represent 18.74% of all fatalities in Bangladesh. Prevalence of stroke in Bangladesh is 11.39 per thousand population with mild regional variation, and prevalence is twice among male. Several independent factors that contribute to the risk of stroke include age, gender, body mass index, a positive family history, cigarette smoking, alcohol intake, hyperlipidemia, hypertension, diabetes, and heart disease. Those factors can induce alteration in physiological processes, resulting in abnormalities in renal, cardiovascular, hepatic function, as well as blood biochemistry. This study was designed systematically incorporate 5 pivotal renal function parameters. It contributes a comprehensive understanding of the complex interplay among acute stroke, renal function, and potential complications, which provide valuable insight into the specific impact of acute stroke on renal health, thereby facilitating precise patient management and improved clinical outcome in the context of acute stroke. So I have designed this cross-sectional study to evaluate renal function tests among acute stroke and normal healthy individuals. Pathogenesis of alteration of renal function in acute stroke. Stroke can have direct impact on kidney through its activation of renal sympathetic nervous system, which regulates glomerular filtration, the renal blood flow, vasopressin release, and sodium and water imbalance. Impaired renal function affects both as a risk factor and a complication of stroke. Renal dysfunction further deteriorates the prognosis of stroke and elevates the rate of recurrence. Alteration of blood flow is autoregulation of blood flow is observed in both brain and kidney vasculature. The brain and kidney, which possesses similar physiological characteristics, collaborate to uphold homeostasis of extracellular fluid by controlling equilibrium of salt and water. The cause of renal dysfunction following acute stroke are also complex and include impairment of central autonomic network, the neuroendocrine system, cerebral autoregulation, inflammatory mediators, and dehydration. Hemorrhagic transformation and cerebral edema are secondary complications that are linked to a drop in EGFR and impaired central autoregulation, which might worsen the prognosis of a stroke. Renal function test in acute stroke. Impaired renal function is commonly identified by assessing renal function test categorized as glomerular function test, which include all the clearance tests, tubular function test, which includes urine concentration and dilution test, analysis of blood, which involving estimation of serum creatinine, serum urea and electrolytes, and urinolysis. Serum creatinine is a non-protein nitrogen molecule that is consistently generated, easily passed through glomerulus, not reabsorbed, and to a lesser extent secreted by proximal convoluted tubules. The concentration of creatinine in blood is very stable and not influenced by external circumstances. Normal value of serum creatinine in male 0.9 to 1.3 milligram per deciliter and in female 0.6 to 1.1 milligram per deciliter. This stability of serum creatinine, indicative of glomerular filtration efficiency and overall renal function, serve as selective marker for acute kidney injury following either stroke subtype. Serum urea is a prominent nitrogenous water-soluble compound that is produced during the catabolism of protein by livers. It is easily filtered by kidney without any active reabsorption and secretion by the renal tubules. More than 50% of it is passively reabsorbed and returned to bloodstream. Serum urea is commonly used as a substitute indicator for renal function, protein intake, and dialysis adequacy. Normal value of serum creatinine 15 to 40 mg per deciliter. Serum urea concentration may rise in patient with acute stroke as a result of hemodynamic worsening and changes in sympathetic activity. Elevated level of serum urea and blood urea nitrogen are the strong indicator of fatalities in individuals experiencing acute stroke. Glomerular filtration rate refers to the volume of glomerular filtrate produced by all active nephrons in both kidneys per unit time. GFR is widely recognized as the most comprehensive measure of renal function. The process of assessing glomerular filtration rate using external indicators is clumsy, expensive, and not easily accessible. Therefore, many equations known as estimated GFR has been created to estimate the glomerular filtration rate based on a person's serum creatinine level, age, sex, race, and body weight. Microvascular injury to both organs can result in renal impairment characterized by low GFR and poor autoregulation. Normal value of eGFR is equal or more than 90 ml per minute per 1.73% meter square. Decreased GFR is linked to a higher death rate and negative outcome in case of acute stroke. Estimated GFR may be served as a possible measure for the severity of stroke, level of impairment, and likelihood of fatalities. Creatinine clearance is a quantitative assessment of kidney's efficiency in removing creatinine from the blood for elimination through urine. Due to physiological properties of creatinine, creatinine clearance is closely related to glomerular filtration rate and commonly used as a reliable test for renal function. Normal value of creatinine clearance 70 to 140 ml per minute. Creatinine clearance is markedly diminished during acute stroke due to a decrease in kidney's glomerular filtration function. This decrease is also linked to widespread vascular injury and established risk factors such as hypertension and diabetes. The inclusions of eGFR along with creatinine clearance enhance clinical relevance by affording insight into acute change and chronic implication for kidney function in post-ischemic and hemorrhagic events. The albumin-creatinine ratio is determined by comparing the amount of albumin discharged in urine measured in milligram to the level of creatinine present in urine measured in gram. It is utilized for early detection of kidney dysfunction and is the preferred approach for assessing increased protein level. Normal value of ACR ratio in male less than 22 mg per gram, in female less than 30 mg per gram. Elevated ACR beyond the typical range might be either a potential cause or a result of vascular disease. It is also associated with prevalent impairment of endothelial and chronic low-grade inflammation, both of which are independently linked to the risk of cardiovascular disease. ACR plays a crucial role in assessing structural integrity, particularly in context of glomerular dysfunction induced by either stroke subtype. Analysis of this study is renal function test, serum creatinine, serum urea, EGFR creatinine clearance, SR ratio may be altered in patient with acute stroke. General objective of this study to assess the renal function test among patients with acute stroke. A specific objective are to find out the socio-demographic characteristic of acute stroke patient and normal healthy individual, to estimate the level of serum creatinine, urea, estimated glomerular filtration rate, creatinine clearance, and albumin creatinine ratio in patient with acute stroke, to estimate the same parameters in normal healthy individuals, to compare those biochemical parameters between patient with acute stroke and healthy individuals. This is a cross-sectional analytical type of study conducted from July 2023 to June 2024, which was carried out at the Department of Biochemistry, Mymensingh Medical College, and the subjects were collected from the Department of Medicine, Mymensingh Medical College Hospital, and sampling done by non-radiopharmaceutical type of sampling. Sample size was calculated by using following formula. After calculation, total 120 subjects were included in this study. Out of them, 60 acute stroke patients were selected as case in group 1 and 60 normal healthy individuals were selected as control in group 2. The subjects were briefed with written consent. Patients of acute stroke were selected from the Department of Medicine, Mymensingh Medical College Hospital. The study subjects were selected based on inclusion and exclusion criteria. Data was collected from face-to-face interview with patient, attendance, clinical examination, and lab investigation. Informed consent was obtained from all participants for laboratory investigation. The required amount of blood, urine were collected, processed, preserved to estimate different biochemical parameters. Data were then processed, analyzed to draw a conclusion. Inclusion criteria for group 1, that means case, acute CT scan or MRI group stroke patient of both ischemic and hemorrhagic type within 48 hours of stroke attack within age 30 to 70 years, hospitalized in Mymensingh Medical College Hospital during study period, and for control normal healthy individual with same age group. Exclusion criteria for both case and control are any acute condition other than stroke, patient with pre-existing chronic hepatic and chronic renal disease, critically ill patient, non-cooperative patients. Serum creatinine was estimated by a method based on Thesis alkaline pigment reaction. Serum urea is estimated by Urea-Barthelot method. Estimated GFR was calculated by coding this is equitably carbonation equation. Creatinine clearance was calculated by using Cobb-Galton equation. Albumin creatinine ratio calculated. At first we done urinary albumin was estimated, microalbumin was estimated by turbidity method, then urinary creatinine was estimated by method Jeffries alkaline pigment reaction, then albumin and creatinine ratio was calculated. Data were analyzed by using SPSS software version 26. Quantitative variables were summarized by mean plus minus SG and compared between group of subjects by using students and pair t-test. P-value less than 0.05 was taken as the level of significance and less than 0.001 was taken as the level of highly significant. The results were presented in the form of tables and figures. Here is the result. Table 1 showing the result of comparison of mean value of age between case and control with not significant difference. Table 2 showing the result of comparison of body mass index and blood pressure between case and control with highly significant p-value. Table 3 showing the result of comparison of mean serum creatinine between case and control. Mean value of serum creatinine in case 1.13 plus minus 0.21 and control 0.39 plus minus 0.26 with highly significant p-value. Table 4 showing the result of comparison of mean serum urea between case and control. Mean value of serum urea in case 37.70 plus minus 10.00 and in control 16.57 plus minus 5.45 with highly significant p-value. Table 5 showing the showing the result of comparison of mean EGFR between case and control and mean value of EGFR in case 71.92 plus minus 20.26 in control 100.73 plus minus 25.02 with highly significant p value. Table 6 showing the result of comparison of mean creatinine clearance between case and control and mean value of creatinine clearance in case 68.25 plus minus 14.35 and in control 89.56 plus minus 28.20 with highly significant p value. Table 7 showing the result of comparison of mean ACR between case and control and mean value of ACR in case 34.96 plus minus 19.71 and in controls 9.81 plus minus 5.49 with highly significant p value. The present study revealed that there was highly significant increase in serum creatinine in case when compared to that of the control group. The result of my study agreed with the study of Acute et al., Agarwal et al., Kushari et al., Snashka et al., and Gavossi et al., and easily with the Julari et al. The present study revealed that there was a highly significant increase serum urea in the case when compared that to the control group, and the finding agreed with the Kushari et al., Agarwal et al., Gavossi et al., and McWalter et al., and easily with the Joe et al. The present study also revealed there was a significant decrease in EGFR in case when compared that to the normal group. Thus, these findings agreed with the Sulaimani et al., Kushari et al., Gavossi et al., and disagreed with the Snashka et al. The present study also revealed there was a significant decrease in creatinine clearance in case when compared to the control group, and finding is agreed with the previous study conducted by Sesta et al. And McWalter et al. The present study also revealed there was a significant increased ACR ratio in the case when compared that to the control group, and this study agreed with the previous study conducted by Laborari et al., Korim et al., Mukhtadiri et al. Limitation of my study: the sample size was relatively small, the parameters were measured only once, thus change over time and other biochemical parameters could not be evaluated. The study was conducted in a tertiary care hospital, which may not represent the patients of primary and secondary center. Samples were taken by the purposive method in which question of personal bias may arise. The purpose of this thesis was to evaluate the status of renal function, serum creatinine, urea, EGFR, creatinine clearance, and ACR in patients with acute stroke and compare them to those found in normal healthy individuals. Mean plus minus SD of serum creatinine, urea, and albumin creatinine ratio were significantly increases, and EGFR and creatinine clearance in of group 1 were decreased significantly when compared with group 2. Acute stroke is an emergency disease and share the same atherosclerotic risk factor with ischemic heart disease, but the association of renal function and stroke is poorly investigated, so that early evaluation may be reduced morbidity, mortality, and complication of acute stroke. Here is some references, and thank you for patience hearing.